present their work and their result. I mean, I'm sorry that the session has been kept right at the end of the meeting, but I am still so happy that people from so many different parts of country who do great work in cataract surgery have all come together. Over to you, sir.
Thank you, sir. Welcome you all in this session. First, I would like to invite Dr. Rahul Deshpande, as he has to leave early for destination. So, Dr. Rahul Deshpande.
Good morning and thank you. I'm very grateful to Dr. Parikshit for giving me the opportunity to present here. This is about the study of comparative study of anatomical and functional recovery of the eye along with patient satisfaction score after manual small incision cataract surgery and phaco emulsification. So this was published in IGO. Introduction: initially cataract surgery was aimed at preventing blindness, you all know. In recent times now it has converted into refractive surgery. We know the advantages of small incision cataract surgery and phaco emulsification, so we will not go in more details in that. As a surgical technique of manual small incision cataract surgery, phaco emulsification is different. Anatomical recovery after cataract surgery because of either surgical technique or with its effect on changing the corneal curvature, corneal sensations, post-surgical inflammation, macular thickness, and tear film will ultimately affect the patient's visual rehabilitation. So methodology: the study design is prospective informational study. Records-based study on the patient who underwent cataract surgery between December 2012 to 2014. Total 310 patients, the age-related cataract fulfilling inclusion criteria were identified and included in the study. 310 patients are equally divided into two groups. One group comprising small incision cataract surgery, 155 cases, and phaco emulsification, 155 cases. Inclusion and exclusion criteria is quite clear in this slide. So the patients with regular astigmatism, patients who underwent uncomplicated cataract surgery were included. Excluded patients were patients with hypermature, complicated cataracts, patients having immature cataract associated with other ocular comorbidity, they were excluded. Methodology: preoperative examination was done, history, visual acuity assessment, keratometry, Sherman's test, and corneal sensations. Postoperative assessment including the best corrected visual acuity, uncorrected visual acuity on the day 1st and day 7th, then the best corrected visual acuity at 1 month after surgery. Vertical and horizontal care readings are recorded. Sherman test was done and corneal sensation was noted, and OCT was done at the day 7 and day 30. This slide shows the details of the statistical analysis results. In small incision group, when post-operative horizontal and vertical keratometry values are compared with pre-operative keratometry values, so there was statistically significant difference. There was no statistically significant difference in the mean horizontal and vertical keratometric values on the post-operative day 1, 7, and 30. In phaco emulsification group, when the post-operative horizontal and vertical keratometry values were compared with pre-operative vertical keratometry values, three were statistically significant. There was a minimal statistical difference in the mean keratometry value on the day 1 compared to the day 7 and the day 7 compared to the day 30 respectively, post-operatively. There was no statistical significant difference in the mean horizontal keratometry value on the post-op day 1, 7, and 30. The post-operative uncorrected visual acuity of 6/9 or better was observed in 29 patients in the phaco emulsification group and compared to 7 patients in the SICS group. So this table says that uncorrected visual acuity was better in phaco group than in small incision group. Post-operative in the day 1, 7, and 30. Results: there was no significant difference in the post-operative best corrected visual acuity between the two groups on the day 30. Results: then anterior chamber inflammation was more in SICS group on the first post-operative day. No significant difference in Sherman's value were noted in the two groups. Statistically significant increase in central macular thickness values on OCT in both groups. So in discussion, anatomical structures that can be affected after cataract surgery are cornea, so corneal edema, stylokeratitis, change in corneal curvature, and corneal sensations. The evaluation of corneal curvature post-operative, pre-operative, and post-operative was done to assess the healing of the wound based on the change in the corneal curvature after surgery. Large incisions up to 6 to 6.5 millimeters, and to some extent cauterization in SICS stability and mean serum test value on the day 7 post-operatively. FECO emulsification group, there was no change in foreign sensations, reduction in the 7th tier, in the 7th day, tier production, but reached baseline value 30 days. So decreased untreated visual acuity in SICS group was due to surgical induced astigmatism, post-operative corneal edema, and more anterior inflammation as compared to the FECO group. So in conclusion, FECO emulsification, of course, as you all know, is preferred over the small incision, but still small incision has its own role in the practice. The faster rehabilitation, less corneal astigmatism, less post-anterior chamber reaction, and better untreated visual acuity in the immediate post-operative period. So limitations of the study, these are there, a single-centered study, therefore the selection bias may affect the results. Follow-up period was only up to the 30 days, long-term effects of those surgical techniques not estimated, post-operative macular thickness not recorded, and large sample size and extensive study period is required. So these are my references. So take-home message, FECO emulsification is preferred technique, but still small incision technique, as you all know, is cost effective and is the best alternative to FECO emulsification. And in certain cases where you are not able to do FECO emulsification or where it is contraindicated, small incision has definitely a role in that. Thank you very much for patient hearing.
Excellent presentation, Dr. Rahul. One thing I want to know, in SICS, where incision was given on steep axis or on the all cases superior incision?
Superior, in all cases superior was given here. In SICS, no? Yeah, SICS, yes.
So it's proven that if you give a incision along the steep axis, right, then manually
Lower the astigmatism. Yeah.
And there is also a study about the superior, supratemporal and temporal. Temporal is the least.
Particularly more affecting the FECO cases because in SICS, if you do incisions clearly, it hardly matters that it is steep or it is flatter. But in FECO, definitely, yes, it is steeper. You want to make it more flatter, so to counterbalance the astigmatism.
Another factor you have already described is limitation. Follow-up was only 30 days. Generally, stabilization after 6 to 8 weeks. Ideally, 3-month follow-up should be.
3 months follow-up would have been there. So we will again make a follow-up of these cases and we may come with some separate results assessing those cases. But many a times the problem is that of the follow-up. That patient after a month or so, they hardly come to follow-up. Or again, we have to call back and then the costing and all that has to be taken care of. So we will definitely proceed in that.
I think Parikshit sir has a study about the comparative study about SICS and FECO.
Yes, sir. Randomized trial. Yes. There is no big difference other than astigmatism.
Okay.
Thank you, sir. Thank you very much.
Now I invite Dr. Bharat Gurnani. He has to leave also for presentation in another hall. Okay.
Good afternoon, good evening, good morning, one and all. Actually, I'll be presenting this study Detailed anterior-posterior segment evaluation was performed. A scan with keratometry, central coronary thickness, and specular microscopy was documented. The surgery of choice was MICS, and group 1 was we used the viscoelastic HPMC, and group 2 BSS plus. The post-operative parameters assessed were intraocular change in intraocular pressure, pachymetry, endothelial cell count, best corrected visual acuity, and keratometry. So as we can see, the majority patients fell into the group of nuclear sclerosis 2 to 3. There was pseudo exfoliation was absent in majority patients, and there was more. All the patients were having controlled diabetes and hypertension. The anterior chamber depth, axial length, uncorrected visual acuity, and fundus was comparable in two groups preoperatively. Comparing the preoperative versus postoperative visual outcome in the two groups, we can see the visual outcome in the two groups at day one and compared day one and 1 month was visually significant, and the value was p value was significant between the two groups at 1 month. Then when we compared the intraocular pressure in group 1 and 2, there was not much change, and the p value was also not statistically significant. And the horizontal k values and the vertical k values were also not significant. There was not much change in the two groups when we compared pre-op versus post-op at 1 month, one day, 1 month. When we came to the center, when we analyzed the central corneal thickness at day 1, the central corneal thickness increased to around 550 in both the groups, and at 1 month it was comparable to the pre-operative value, but the values were not statistically significant when compared at one day 1 and day and 1 month. And but the main parameter, the target primary objective was to assess the endothelial cell density, which as per our surprise, or we may say like in the group 1 with the OVD, endothelial cell count was comparatively lesser considering comparing with the VSS plus. The endothelial cell loss was around 9.7% at 1 month and in group 1 and 4.8% in the group 2, and the values were statistically significant. So, coming to a discussion of, as you know that endothelial cell morphology and physiology, the sodium potassium ATPase form bicarbonate gradient, the monolayer of endothelial cells along with hexagonal arrangement maintain the corneal transparency as well as dehydrated state, and as reported in the literature, the average endothelial cell count is 2500. So, what are the factors which cause endothelial cell loss? And we know hydrogenic trauma during surgery, irrigation aspiration, senile degeneration of endothelial cell loss, longer duration of the surgery, and excessive ultrasound during phaco, large nucleus size, cataract surgery, weight can affect, excessive chatter, free-floating fragments, small pupillary diameter, and the nucleus rubbing the endothelium. So when we went to the literature review, we see that Meganol has documented phaco small pupil less than 5 millimeter causes more endothelial cell loss. When we see the similarly, Perez et al. Also reported that smaller the pupil in diameter, more the endothelial cell loss. And Jagani et al. They showed that endothelial cell loss at 1 week, 6 weeks, and 3 months in both the techniques FACO and MSICS. No statistical significant difference was found. Ganekar and Nagaraja showed that CCT remains unaffected at 6 weeks from baseline. Thakur et al. Showed that around 16% reduction in endothelial cell count after SICS, which was comparable to endothelial cell loss after phacoemulsification. And Bogota et al., as we discussed just now, no difference in endothelial cell loss and SICS, but there was a small astigmatic shift. So there have been multiple studies which have documented different parameters, but as such there is no large-scale study which assesses the endothelial cell loss during the same step using two different techniques in SICS. So the strengths are the prospective nature of the study. We had a very large sample size and not published in the literature yet, and computer-based randomization was done to avoid selection bias. The limitations were follow-up period was less than 1 month or around 1 month, and the other morphological endothelial parameters like coefficient of variation, standard deviations were not compared. So to conclude that we had around 100 patients in both the groups, which is comparatively higher from the previous study to get better insight about endothelial cell loss after SICS. The mean preoperative and postoperative visual acuity were not much affected. This shows that the visual acuity is not affected much by different cataract techniques. The IOP in two groups was also not nearly similar at the 1 month. This shows that there is no to minimal corneal edema postoperative to group which could impact the IOP. The horizontal and K value and vertical K values in the two groups were also nearly identical. This shows that even if you modify different steps of SICS, it does not affect the keratometry values much. And the endothelial cell loss to a surprise was more in the OVD group compared to the BSS group. We show that OVD may not always be necessary when we are lacking it. So endothelial cell protection can be better with BSS plus in experienced
nebulous grading. You have your inclusion criteria is 1 to 5. I
Yes,
think in randomization it is very difficult. In grade 1, naturally, nebulous will come very easily compared to grade 5 or grade 4. So that is one thing. Second thing is on follow-up on day 1 there is lot of edema, lot of inflammation.
Okay.
So you may not be able to record the endothelial cell count and other parameters. And follow-up should be more
Yes,
to know the actual effect of these two methods.
yes, sir. Thank you.
Very good.
Now I invite Dr. Rija in Anthony.
Good morning everyone. I'm presenting my study on a comparison of subcutaneous block with perivalvular block in small incision cataract. No financial interest. Local anesthetic techniques are popular in ocular surgery due to its high safety, high success rate and faster patient recovery as compared to general anesthesia that is used in other surgeries. The conventional perivalvular technique is most commonly used for intraocular procedures. But the newer subcutaneous technique is an emerging one which may prove equally effective but with less risk and complications. The aim of my study was to compare the efficacy and safety of the subcutaneous block, the perivalvular block, with respect to analgesia, akinesia, complications such as echosis and subconjunctival hemorrhage. It was an observational study which was done comparing both the techniques with 35 patients in both the groups. Subcutaneous anesthesia is a technique of injecting local anesthetic agent into the posterior subcutaneous space with prior use of topical anesthetic drop. 4 ml of 2% lidocaine with adrenaline is infiltrated into the posterior subcutaneous space using a blunt tip curved cannula through a conjunctival neck that is made approximately 7 to 10 millimeter in the inferior nasal quadrant on the limbs. Analgesia was monitored using the Wong-Baker scale from the time of administration of the block to 4 hours post-operative period. It was monitored by light, moderate and intense. Level of akinesia was assessed on a grade of 0 to 8 where each recti muscle was given a score of 0, 1, 2 being nil akinesia, partial akinesia or complete akinesia. Time of onset of akinesia was noted in seconds. Presence or absence of chemosis, subconjunctival hemorrhage or any other complication was also noted after administering the block. My inclusion criteria was all patients undergoing SICS under local anesthesia. Exclusion criteria was those patients who had any sensitivity to xylocaine, anxious or non-cooperative patients, or any history of previous intraocular surgery, injury or any inflammation. Coming to the results, it can be seen the baseline pain grade distribution or during the administration of the block. We can see that subcutaneous group had absolutely no pain, around 97.1% patients, whereas perivalvular during the administration had mild pain, that was around 91.4% of the patients that was given perivalvular. During perioperative and during post-operative, we can see that there has not been a difference, statistically significant difference in the pain in both the groups. Akinesia, when we compare the akinesia in both the groups, we can see that in subcutaneous, they had a maximum patient that is 74.3% had a score of 4, which is partial akinesia. Whereas in perivalvular, they had absolute akinesia, which was 82.9% of the patients who were given perivalvular. Presence of chemosis was comparatively a little more in perivalvular group. But when we look into the subconjunctival hemorrhage, most of the patients, the subconjunctival hemorrhage was absent in both the groups. In perivalvular, it was absolutely not present, but in subcutaneous, there was an 8.6% of the patients who developed subconjunctival but the perioperative and post-operative statistically did not show any significant difference. Comparing the time of onset of akinesia, it was statistically faster in the subtenous group as compared to the perivulvar group. Although perivulvar technique is considered safer as compared to the old retrovulvar technique, it carries risk of brainstem anesthesia and globe perforation. The subtenous technique is hence gives a good amount of analgesia and akinesia during the procedure. So, and it also decreases the incidence of patient anxiety and the painful experience during administering the block, which is usually seen in perivulvar block. It also avoids any damage to the vasculature and the optic nerve because we using a very blunt cannula instead of a needle, and we require comparatively less volume of the anesthetic agent. The akinetic effect of subtenance is less as compared to perivulvar, but for a procedure, a short procedure like small incision cataract surgery, the partial akinesia would suffice. However, considering the analgesic and akinetic effect of subtenous block, it can be used as an alternative to perivulvar block for short intraocular procedures such as SICS. Thank you.
Thank you. Very good presentation.
Thank you, sir.
2-3 points again I wanted to discuss. As there is blunt cannula usually in cases of subtenous anesthesia. So naturally akinesia chances of perforation is less and less, almost you can say negligible, and but always akinesia is less compared to perivulvar. So it is always preferable, but patients should be more you can say cooperative in subtenant group, because if patient is not cooperative or even surgeon is not comfortable, then naturally one has to shift to perivulvar. I want to ask from the house, in cases of perivulvar anesthesia, chances of perforation is there. So which type of needle you people use? 23 gauge, 24 gauge or 26 gauge? 26 gauge.
Most of us are using a 24 gauge probably. But if you use the 26 gauge, then there is a less chances of perforation.
That is what I want to emphasize. Basically, when I joined here in AIIMS Patna, almost all of our senior students were using 24 gauge needle. So chances of with 23 or 24 gauge, basically there is combined effect, retrovulvar as well as perivulvar, not the only perivulvar. So that is why chances of perforation is more, even retrovulvar hemorrhage is more. But when you use 26 gauge, chances of perforation is almost negligible, minimized very well. So one should use 26 gauge in perivulvar anesthesia.
And the second thing I want to ask you, the subtenance, the patient needs to be cooperative. How we can practice in the high volume sector? Because I have been to the urban recently. They have started using subtenance in a high volume. All 3 cases they are doing subtenance, and they have done a study also. So it has, because a lot of things, complication has reduced. But what is the practicality? Have you used it? Because they are doing subtenance under naked eye with a self-illuminated light.
Yes, yes. Problem is that you may not go to the subtenance. You may end up in a subtentravelar space, and there is a lot of chemosis, and its effect may not occur. So again, with naked eye, again it is very difficult. Ideally, it should be given under microscope.
Yes.
Or
so you are giving it under microscope.
In the study, yes, sir. Everything was given under microscope.
They were giving it under without any. So thank you.
Anyway, very good presentation.
Thank you, sir.
Thank you. Now I invite Dr. Prerna A. Sethi with her presentation.
Good morning. I first of all thank the scientific committee and Dr. Parishit for inviting cataract surgery at a tertiary center in South India with my other co-authors, Dr. Sham Balena, Dr. Saujanya, Dr. Uma, Mr. Satyanarayan, and Mr. Rajvardhan. There were no financial disclosures. As we know that cataract surgery is the most frequently performed ophthalmic surgical procedure worldwide. So wound leakage is not uncommon and early detection is important so that the efforts are made to restore the corneal integrity which can be implemented immediately. If it's not caught early, patients are at risk of developing the cascade of sequelae which also includes endophthalmitis. IOL dislocation can occur within a few days or within a few months. The incidence of IOL dislocation within the first week after the surgery is 0.2 to 2.8% as put in the literature. And repositioning of the posterior chamber IOL in the ciliary sulcus allows the dislocated IOL to be restored to a position closest to its original fit. The proficiency in cataract surgery is one of the main objectives of surgical training during an ophthalmology training. So this study aims to report the incidence of early surgery rates after manual SICS and also it compares the rate between the trainees and experts. And to our best knowledge, this was the first study in literature which studied on the resurgery rates in manual SICS and compared it between the trainees and experts. It was a retrospective single-center study and the subjects included were from the duration 2012 to 2022. The inclusion criteria, the resurgery which was done within 1 week from the day of primary surgery and the manual SICs performed by trainees which needed resurgery were identified and compared with those done by the experts. And all the resurgeries were performed by the experts. With the help of electronic medical records at our center, we collected the data which included the demographics and the best corrected visual acuity. The factors that studied were the type of resurgery which was performed. That is either in the form of wound resuturing, IOL repositioning, cortical wash and AC wash were included and the rate was compared between the trainees and experts. Statistical analysis was performed using the software Stanford Ocean 14. Categorical data was described as proportions and continuous data as mean plus or minus standard error. The data was analyzed by frequency, percentage, chi-square test and Z test and P less than 0.05 was considered statistically significant. So in coming to the results, out of the 19,515 eyes that underwent manual SICS, 369 eyes underwent a resurgery during the study period, which accounted for about 1.89% of the total surgeries. Out of this, 213 were males and 156 were females, and most of the cases were in the age group of 61 to 70 years. And 205 were from a rural background and 164 from an urban background. So out of this 369 eyes, 176 underwent wound resuturing, 133 underwent IOL repositioning, 36 had cortical wash and 24 had an AC wash. So these are few pictures of our patients who underwent these surgeries. In this, where there is a shallow AC and significant corneal edema, which underwent a wound resuturing, and IOL repositioning in this case, and the dense cortical matter in the visual axis, which had to undergo cortical wash. In this patient underwent a cortical wash with IOL reposition. When we compare the rates of resurgery between the trainees and experts, we found that the wound resuturing were comparable. That was out of the 65 cases, this was between 2018 to 2022. And out of the 65 cases, 31 were done by trainees and 34 by the experts. Whereas IOL repositioning, about 63.1% were done by the trainees and 73.9% were those done by the trainees, that was taken up for cortical matter aspiration. And 64.7% of all the AC washes taken up for resurgery was done by the trainees. So these are few of the literature that we looked into. And the most common indication for reoperation included retained nuclear fragmentation, intraocular lens dislocation and incision leaks. The effect of surgeon experience upon outcomes may persist, as one of the study done by Menda et al. Suggests that the complication rates decreases over the first 300 to 3,000 cases in independent practice. Our data added to this as early training cases were at a greater risk for reoperation, especially IOL repositioning, cortical wash and AC wash. However,
wound resuturing rates were comparable between the trainees and the experts. A study done by Chi et al. Suggested that almost one-third of the incisions leak. So this was comparable to our study where out of all the resurgeries, 47.6% were that of wound resuturing alone. And in our study, there were 36.04% of resurgeries were IOL repositioning, that was 0.6% of the total manual SICS performed. It was consistent with the study done by Greenberg et al., where they found that 0.9% patients presented with IOL dislocation and needed a IOL repositioning. So what we did was we utilized the international ICO Oscar scoring to assess the trainees' performance and also in turn impact of a surgical training program. And to monitor and reduce the incidence of resurgeries, the post-operative assessment was performed by the consultants. The trainees do the surgeries under supervision of a well-experienced consultant until they are confident. So after this analysis of 10 years, what we did was we started a retrospective evaluation of surgical videos of each trainee and discussed the theoretical and practical approaches toward improvement in the surgical competence of theirs. To conclude, a careful preoperative assessment, training under supervision and other measures can be taken to reduce the resurgery rates, and timely diagnosis and early treatment can give better outcomes and prevent devastating complications like endophthalmitis. The limitation of our study is that we did not include the preoperative and intraoperative factors which led to the resurgery rates and also the difficulty levels of the surgery that we compared. Thank you.
Excellent presentation. Thank you. Any questions? Just one or two comments. Level of expertise and even among trainees is different. The first year trainee level of expertise is different. So maybe this study can be done on the basis of experience.
Experience of the trainees.
After maybe post graduation, 1 year, 2 year, 5 year like that.
Yes, we'll look into that. Thank you, sir.
Now I invite Dr. Arvind Kumar Moria. He is additional professor and head in AIIMS Vivi Nagar, and he is doing lot of work in SICS. So he will be speaking on Moria technique of nucleus hydroexpression. In the meantime, if it is taking time, then we can call upon another presenter. Okay. So in Bihar, very few centers are performing very high volume surgery, and Akhand Jyoti Eye Hospital is one of the center where lot of cataract surgery is being done, and who better than Dr. Ajit Poddar sir? He will be speaking. He is medical director there, so he will be speaking on the experiences he has seen through this long years in Akhand Jyoti Eye Hospital.
Thank you, Dr. Amit, chairperson, and all the seniors and delegates. I have been told at a very short notice to talk about the Akhand Jyoti Eye Hospital's contributions to SICS. And thank you, Dr. Parikshit Gogate sir, for giving the opportunity. And honestly saying, I don't know what is right, whether SICS has contributed in our life and Akhand Jyoti's future, or Akhand Jyoti has contributed to SICS. So it's vice versa. Actually, SICS has contributed more to Akhand Jyoti and in all of us. So Akhan Jyoti Hospital is a tertiary eye care hospital. It's a high volume setup which has been started in the year 2006, and in the very first year we had done a 7,000 surgery, and right now we are at 375 beds hospital with 76,000 surgery per aider. So the this is about the volume. Till date, we have done about 6,58,730 cataract SICS only. I am talking about the SICS, this graph. And we are looking forward to do about 15,06,000 manual SICS apart from the FECO. We are also doing about the, I think, maximum number of FECO. So the way SICS has impact, so out of a 6,58,730 surgery done, we had to screen the 52,69,842 patients. And among them, 76% were bilaterally blind. The complication ratio was 0.9%, and the percentage of IOL surgery was 99.7%. Endophthalmitis, whatever the crude data we had, the endophthalmitis ratio is 0.01%, and we had trained ophthalmologists till now 61. So the training part, this is so far 61 ophthalmologists have been trained and refined their skill in manual SICS, and another 300 ophthalmologists will be trained by 2030. Structured fellowships is now started. And we have a surgical wet lab and the eyesight simulator in place. We have a separate training operation theatre led by dedicated trainers. And to promote research, Akhan Jyoti Hospital aims to publish 10 papers on manual SICS technique per year in peer-reviewed journal. So these are the training operation theatre, wet lab and the eyesight simulators. So I don't know what to say. Just I want to say so that how do we do the routine surgery? It's a 99% surgery is being done by this method. After we first make the side port, and after staining the capsule, we inject viscoelastic to make the eyeball firm. And then after taking the conjunctival flap, we make the main incision 1.5 millimeter beyond the limbus, and with the crescent we make the corneoscleral tunnel. First you create the plane between the cornea, this sclerocorneal plane should be uniform, and then we enter with the 3.2 cratome, and there should be always a forward movement. And after puncturing the anterior capsule, we tend to make a larger rhexis in manual SICS. All of us we know. If we could not make the circular rhexis, then make it a oval or a heart-shaped rhexis. It will help in the nucleus, and we prolapse the nucleus by hydroprolapse. And most of us will, majority of the, if it's not coming with the hydroprolapse, then we do with the Shinsky hook. The two things I want to highlight, that we, after doing the cortical aspiration, we, actually I am not finding the cursor, otherwise I would have moved it fast. That we implant the intraocular lens in BSS, under BSS, and we prolapse the, we do the, this is a black cataract, and sometimes we do SICS in this case. And this is a, sometimes manual SICS, even in the phaco surgeon, it acts as a rescue. This is a case, we are, I was doing, it was posted for phacoemulsification. It's a grade 3 to 4 cataract. After doing the rhexis, we did the hydrodissection, and we rotated the nucleus, and during rotation we felt like the nucleus was sinking into the vitreous, and we tried to retrieve the nucleus with the help of two Shinsky hook, but we could not. So we felt like it will sink into the vitreous, and the patient is under topical. So we did make once you are an SICS surgeon, you can always make a SICS tunnel, and we plan to convert into the SICS under topical. So after entering into the anterior chamber, we retrieve the nucleus with irrigating vectis. After taking out the nucleus, we did the bimanual vitrectomy with the separate side port, and after taking out all the remaining cortical matters with the same vitrectors and doing vitrectomy, we implanted 3-piece IOL in the sulcus. So that's what I could say. Thank you. Thank you. Thank you.
Numbers and doing great service to the society, and I would say to young ophthalmologists also, they are getting surgical exposure at your center. Once again, thank you. And another thing I have learned in the first case, you have shown before
light off कर दीजिए.
making tunnel, first you have entered into the anterior chamber, and after putting visco. So again, that is one of the learning point. Whenever you are making tunnel, your globe should be tight. Otherwise, there is chances of premature entry.
Yes.
Thank you, sir. Dr. Moria is prepared for his talk. So, Dr. Moria.
Good morning all, and thank you so very much for giving me the opportunity. So I will be speaking on our innovation, that is a Moria's technique of nucleus hydroexpression, and it is very endothelia friendly. So what is the importance of endothelia? In brief, it allows leakage of solutes and nutrients from the aqueous humor to the more superficial layers of the cornea, while at the same time pumping water in the opposite direction from the stroma to the aqueous. So dual function known as the pump leak hypothesis. The nutrition of the corneal epithelium, stromal keratocytes and corneal endothelia must occur via diffusion of glucose and other solutes from the aqueous humor across the corneal endothelia and keep the cornea in a dehydrated state. So it transports water from the stromal facing surface to the aqueous facing surface by an interrelated series of active and passive ion exchangers. So it's very critical to this energy driven process is the role of sodium potassium ATPase and carbonic anhydrase. So as we all know that cataract surgery is the most common ophthalmic procedure performed nowadays, and continued research, advances in surgical techniques, development and modification of instruments and newer pharmacological advancements have revolutionized cataract surgical management. And the surgery has evolved from extracapsular cataract extraction to manual SICS and phacoemulsification. And the recent innovations are flax and robotic cataract surgery. And the elective cataract surgery is associated with some endothelial cell loss, as endothelial cells cannot regenerate and cellular decline below an acceptable limit of 1000 cells per millimeter square can lead to corneal decompensation. And earlier studies have reported 16 to 67% of endothelial cell loss during phacoemulsification, and manual SICS there is loss of 4 to 17% as per various literature review. So less viscoelastic cover to the endothelia, nucleus prolapse, nucleus delivery and continued jet of irrigation and aspiration are the significant factors causing endothelial cell loss during M6. So we have developed this indigenous technique of nucleus hydroexpression. So there is a specially designed beveled up Moria's hydrocannula. So this was the first design. So as you can see, the whole length is 24 millimeter and there is beveled up, the main port is there. So it has a this opening of 0.6 millimeter, and then there are two openings on the sideways on the right and left side with the opening of 0.3 millimeter. So it is there, the side opening, it acts when the fluid passes through it, so it acts to maintain the chamber. So we don't need the anterior chamber maintainer. So this is the advantage of this hydrocannula. So in this is a brief about the technique under peribulbar subtenon superiotemporal, the temporal main incision, the side port and appropriate rhexis after staining with blue dye and routine hydro and delineation and nucleus prolapse into the AC. Then this specially designed beveled up hydrocannula is attached to a 5 ml syringe of BSS plus or any fluid you want, is inserted behind the nucleus under direct visualization and through sideways motion. Nucleus is engaged in the sclerocorneal tunnel and counter pressure at the posterior lip leads to its removal. And the curved angulation prevents any tissue trauma, as there are 3 holes for fluid, 1 central trip and 2 holes on both sides. So there is no anterior chamber prolapse and no anterior chamber maintainer is needed. So these are 2 videos. So routine SICS, I prefer mainly temporal or superiotemporal main incision, and using varied type of incisions like the chevron or the radial cut if the nucleus size is large. So after pushing the dye and its removal, because it's an intumescent type of cataract, so we need a very good visualization in such kind of cases, and then very controlled rhexis is made. So it was very intumescent, so I prefer the microcapsular forceps, routine entry, and then prolapse of this white mature cataract into the anterior chamber. And now this specially designed hydrocannula goes inside, and there is no need of anterior chamber maintainer. It comes out the very large nucleus and only 6 mm with good side pockets, and we can put then the PMMA or any foldable IOL or multifocal. So this is again a very large nucleus, you can see in this case. It is prolapsed into the anterior chamber. This cannula goes inside, a little bit pressure at the lip, and it comes out very easily. If it doesn't comes out, then we can give radial cut. So this study has already been published, and I think Dr. Gurnani has already presented. So that is our study. So just recently SICS Spatial Journal in the Indian Journal of Ophthalmology, this study has been published as a randomized control trial. So I won't go into the details. So just the 2 brief finding, very important finding. First is the change in the endothelial density. So in the OVD group, the visco expression, there was 9.7% loss of the endothelial cell, and whereas in this technique 4.8% only. And also this was a very strange finding. IOP also decreased and it was maintained till 18 months. So in the OVD group, IOP came down to 8.7%, and in the hydroexpression technique it comes down to 7.5%. This is something new that we have come out with our study. Otherwise we have known that the phaco lead to decline in the IOP. So in the conclusion, a recent article reported acute shortage of OVD in the European market and is likely to affect the whole world because of the scarcity of the raw materials. Hence, we have to look for alternative of OVD and also minimize its uses in various steps of surgery. As per our knowledge, this is the first large-scale analysis highlighting the pachymetric, IOP and endothelial cell changes during nucleus removal by 2 different nucleus removal techniques of M6. So this technique is a simple and repeatable technique of nucleus hydroexpression using a new innovative hydrocannula, and it is under patent. Thank you so very much.
Presentation, Dr. Moria.
And congratulations for the innovation for that cannula.
Thank you, sir. Thank you so very much.
One thing I want to know, in case this cannula is attached with
Any 5 ml.
or
Dispovan.
Vidi.
Dispovan.
So in Dispovan, basically, is there a continuous flow? It depends basically when you are doing it manually.
Yeah.
Chances of continuous flow is there, or shaky type of
No,
interval?
it's continuous because of the two, there are two other openings are also there. So there is a regular, I could have shown into 3D or after the patent, we will show the whole technique. How it acts, how the fluid goes out and it maintains the anterior chamber.
In
There is
softer,
no shallowness of anterior chamber. This is the,
softer cataract, it is easy, but in hard cataract, I think it will be difficult to maintain the interchamber because of
I,
the larger nucleus and
Larger
maybe
incision size.
yeah, incision size and flow may not be adequate for.
I've shown you the first video, that was a very hard cataract. And the second was a little bit softer, but very large, still very large.
That was mature.
Yeah.
I am talking about grade 4 and
Yeah,
grade 5.
in that case, we need to give a lateral radial cut. There is no harm in that. And applying one suture.
When chamber becomes shallow, then there is chances of basically negative pressure will create.
Yeah,
So that will
definitely.
cause basically PCR or even dialysis also.
Yeah, yeah, definitely.
So, it is long term. Basically, you have to go for a study. Only 30 days follow up is there.
Yeah, that's already published, but now we have data of 18 months.
And
So,
data of stigmatism also, surgically induced stigmatism in these cases.
yeah, that is also there. That will be published in a separate way.
Okay.
Yeah.
Okay. Thank
Yeah.
you.
The SIA came from 0.58 to 0.92. The surgically induced astigmatism means after using all different incisions and which the chevron fares better in all those incisions.
Again, it depends on nuclear sources of different grade. In a smaller grade, there will be a smaller incision.
Yeah.
And lesser SIA.
Definitely. The incision size is in direct correlation with the SIA. Definitely it is.
Nice.
Thank you so very much.
Now, the last presentation. Again, Sri Sai Lions Eye Hospital is doing volume surgery in Bihar. And again, I invite Dr. Amarnath Chaudhary sir to share his experience in Sri Sai Lions Hospital.
Respected dignitaries on dais, ladies and gentlemen, this very I feel very the topic for today as I prepared on the short notice is SICS Veni Vidi Vici. What is the meaning of Veni Vidi Vici? I will say a phrase for phrase which means I came, I saw, and I conquered. This phrase was first used as it is reported. This phrase was first used by Julius Caesar in a letter to Roman Senate, which means after he won the war somewhere in Turkey. So the SICS we are doing the target of SICS very high volume surgery because in Bihar and even in India cataract backlog is very high, and to clear the cataract backlog high volume surgery centers are established, and the Sri Sai Lions is primarily a charity-based eye hospital situated in the heart of Patna. The prime objective of Sri Sai Lions is reach to unreached. Means we try to go to the remotest place of Bihar, and we are covering at present more than 20 districts of Bihar by establishing vision centers. Patients get examined there and referred to the base center where they get operated. So presently we are doing more than
surgeries per annum. Altogether, we have operated, this I am talking about SICS only. Altogether, we have operated more than 2 lakh SICS surgeries at Sri Sai Lens Netralaya. And other activity of Sri Sai Lens Netralaya is we are training to junior ophthalmologists for SICS and PFO. So a 2 years fellowship in SICS or cataract surgery is being done there. Many fellows have passed out from our science and they are doing very good in their fields. Now, how we are doing high volume cataract surgery, how we are performing high volume cataract surgery. I am just giving a basic outline. So, anesthesia, retroperi, subvenous, topical, everything meticulously discussed here and in other papers. The Science Central, there we prefer peripheral anesthesia. Topical anesthesia is also good, but patient cooperation is required. And in my experience, I have seen topical anesthesia more surgical time is taken. So incision, we give dry renal from incision with crescent knife only. We don't use blades or other things. With single crescent knife, we put from incision. We don't make connector flaps. We don't do cautery to avoid cautery-related problems. And only jet of BSS with 24 gauge cannula at the incision site make the area bloodless or clears the area. The straight incision is avoided because straight incision compromises human integrity and high surgical induced astigmatism is reported in straight incision. In capsulotomy, can opener in velar capsulorhexis, all type of capsulotomy is done, but we are focusing on capsulorhexis only. In Nepal, special type of capsulotomy I have done, or it is still practiced there. It is called Himalayan capsulotomy. Since major part of my experience is from Nepal only, so Himalayan capsulotomy, they do capsulotomy with a 26 gauge needle straight. They don't make bed or they just enter 26 gauge needle inside AC. And they just make 2 nicks to make envelope. And they come out, then they extend the incision with keratome. Nuclear delivery, every every types of nuclear delivery from glutathione incision to visco expression, vectors, and ultimately I am settled on fish hook delivery. Fish hook again was designed at Nepal, Lahan. Lahan is a very large high volume cataract surgery center. So Lahan fish hook was designed. It is made simple from 30 gauge needle or 26 gauge needle. It is just bent like fish hook, and delivery is done with the fish hook. And IUL we implant under BSS. Visco is not given just to save the time. Unhydration and patching of the eye is done. We don't give any subconjunctival injection or intracameral injection of antibiotic. Challenges for SICS. So infection prevention and control. Infection is still a problem for all high volume cardiac surgery centers. Infection prevention and control is one challenge. Management of complications, another challenge. Financial challenge, it is universal, is mainly for charity-based centers. Increased operational and surgical cost and insufficient and delayed payments from donor agencies. Despite these challenges, the journey continues. Thank you.
Thank you, sir, for sharing your experience. Again, you people are doing great job to the society and for young ophthalmologists. Thank you. This concludes the session. Thank you all the chairmen, speakers, and above all the delegates who attended this session. Thank you all.